Hello, I am Dr. Owen On, and welcome to the fourth installment of the Boring Lecture Series. In this lecture, we will be focusing on the canine cruciate ligament. Today's paper of interest is a biomechanical study, evaluating two different locking plate constructs used in tibial plateau leveling osteotomy, commonly abbreviated as TPLO, in the canine patient. The title of the paper on which this lecture is based is Biomechanical Comparison of Tibial Plateau Leveling Osteotomy performed with a novel titanium alloy locking plate construct versus an established stainless steel locking plate construct. The study was published in the journal Frontiers in Veterinary Science and is available as an open access article. This lecture will proceed slowly, carefully, with emphasis placed on precision, completeness, and repetition where appropriate. We will begin not with the plates themselves, nor with the results of the biomechanical testing, but rather with a broad discussion of the clinical condition that motivated the development of these implants and the surgical procedure in which they are used. The cranial cruciate ligament, or CCL, is a primary stabilizing structure within the canine stifle joint. Its function is multifactorial and includes resistance to cranial translation of the tibia relative to the femur, limitation of internal tibial rotation, and contribution to overall joint stability during weight bearing. In dogs, disease of the cranial cruciate ligament is a common orthopedic condition. It is widely recognized as one of the most frequent causes of hind limb lameness in the canine population. Unlike the acute traumatic anterior cruciate ligament rupture often described in human athletes, canine CCL disease is more frequently degenerative in nature, progressing gradually over time before culminating in partial or complete rupture. This degenerative process may be influenced by a number of factors, including but not limited to conformation, body weight, tibial plateau angle, genetic predisposition, chronic inflammation within the joint, age and activity level. The end result of cranial cruciate ligament insufficiency is joint instability. This instability leads to abnormal joint mechanics, pain, progressive osteoarthritis, and functional impairment. The clinical importance of CCL disease extends beyond individual patient welfare to encompass significant economic considerations. According to the study's introduction, in 2005, the annual cost of medical and surgical management of CCL rupture in the United States was estimated to be in excess of $1.3 billion. This figure has likely increased in the years since that estimate was made. This substantial economic burden reflects not only the frequency of the condition, but also the complexity of surgical intervention, postoperative care, and management of complications when they occur. The high prevalence of this condition means that any improvement in surgical technique, implant design, or complication reduction has the potential to affect a large number of patients and their owners. While conservative management may be attempted in some cases, particularly in small dogs or those with limited activity, surgical intervention is commonly recommended for medium to large breed dogs in order to restore function and slow the progression of osteoarthritis. A variety of surgical techniques have been developed over the years to address CCL deficiency. These techniques can broadly be categorized into extracapsular stabilization techniques, which attempt to replace or augment the function of the ligament using sutures or synthetic materials. Osteotomy-based techniques, which alter the geometry of the tibia to neutralize forces acting across the stifle joint. Among the osteotomy-based techniques, tibial plateau leveling osteotomy, or TPLO, has become one of the most widely performed procedures in veterinary orthopedic surgery. The widespread adoption of TPLO as a treatment modality is documented in the veterinary literature. The study cites survey data indicating that TPLO is among the most commonly performed procedures for stabilization of cranial cruciate ligament deficient stifles in dogs. This prevalence in clinical practice makes the evaluation of TPLO-related implants particularly relevant to the broader veterinary community. Because so many surgeons perform this procedure with such frequency, advances or modifications in implant design that affect outcomes, complication rates, or mechanical performance are of considerable interest. The TPLO procedure was developed with the goal of eliminating cranial tibial thrust during weight bearing by altering the slope of the tibial plateau. Rather than attempting to replace the function of the cranial cruciate ligament directly, the TPLO changes the biomechanics of the joint such that stability is achieved dynamically during stance. In simple terms, the procedure involves performing a curved osteotomy of the proximal tibia, rotating the tibial plateau segment to achieve a target tibial plateau angle, stabilizing the osteotomy using a bone plate and screws. The success of the TPLO procedure relies not only on accurate execution of the osteotomy and rotation, but also on stable fixation of the osteotomy site during the healing period. This brings us, inevitably and unavoidably, to the subject of orthopedic implants. After the osteotomy is performed and the tibial plateau is rotated, the two bone segments must be held in a stable configuration while bone healing occurs. During this time, the construct is subjected to cyclic loading associated with normal ambulation, weight bearing, and muscle forces. Inadequate fixation can result in loss of rotation, implant failure, delayed union or non-union, fracture propagation, catastrophic construct failure. Therefore, the choice of implant and fixation strategy is a critical component of TPLO surgery. Complications following TPLO surgery occur with measurable frequency and have been documented extensively in the veterinary literature. The study acknowledges that surgical site infection is one of the most common complications after TPLO. The incidence of surgical site infection, abbreviated as SSI, following TPLO has been reported to range widely in different studies. The study references infection rates ranging from as low as approximately 1% to as high as 21%. Depending on various factors including implant type, surgical technique, patient characteristics, and perioperative management. Surgical site infection has multiple negative consequences. It adversely affects patient well-being, diminishes client satisfaction, increases financial burden on the owner, and often necessitates an additional anesthetic episode and surgical procedure for implant removal. Given the frequency with which TPLO is performed and the potential for complications such as infection, there exists substantial motivation to develop implant designs that may reduce complication rates while maintaining or improving mechanical performance. Orthopedic plates used in TPLO commonly employ locking screw technology. Locking plates differ from traditional non-locking plates in that the screws lock into the plate, creating a fixed angle construct. In a locking plate system, the screw head threads into the plate. Stability is achieved through the screw-plate interface rather than friction between plate and bone. The plate functions more like an internal fixator. This design offers several theoretical and practical advantages, including reduced reliance on precise plate contouring, preservation of periosteal blood supply, increased stability in osteoporotic or compromised bone, improved resistance to cyclic loading. Locking plates have become the standard of care for TPLO fixation in many practices. It is important to understand the fundamental difference in how locking plates achieve stability compared to conventional plates. Conventional bone plates rely on friction between the plate and the bone that is generated by compression of the screw head against the plate. When a conventional screw is tightened, it pulls the plate tightly against the bone surface, and this compression creates frictional resistance to movement. In contrast, Locking screws create a fixed angle relationship between the screw and the plate by threading the screw head into threaded holes in the plate itself. This creates what is effectively an internal fixator, where the screws and plate form a single, unified construct. The study explains that failure of conventional plates is often attributed to screw loosening and axial pull-out of individual screws occurring sequentially. However, failure of locking systems requires concurrent axial pull-out of all screws simultaneously, or compressive failure of the bones surrounding the screws. The force or load required to cause failure of all screws simultaneously greatly exceeds that required to cause failure in sequential fashion. This mechanical advantage is one of the key reasons why locking plate technology has been widely adopted in veterinary orthopedic surgery. There is evidence in the veterinary literature suggesting that locking screw fixation may reduce infection rates in TPLO constructs. The study cites a retrospective investigation of 208 dogs that underwent TPLO using a variety of bone plates. In that study, non-locking constructs were associated with a higher incidence of infection compared to locking constructs, with this difference reaching statistical significance. The authors of that previous study hypothesized that the protective effect of the locking plate may be due to several factors. Lack of disruption of the underlying cortical bone perfusion, in comparison with conventional plates which compress the undersurface of the plate directly against the cortical bone. Decreased incidence of inflammatory complications resulting from loosening of the hardware, as loose hardware has been shown to propagate an inflammatory response and promote infection. A faster rate of bone healing because of more stable fixation, with stimulation of primary rather than secondary bone heli. These considerations provide additional rationale, beyond purely mechanical performance, for the continued development and refinement of locking plate systems. We will now move on to materials. Orthopedic plates are commonly manufactured from either stainless steel or titanium alloys. Each material has distinct mechanical and biological properties. Stainless steel, typically 316L stainless steel, has long been used in orthopedic implants. Its advantages include high strength, relative affordability, long history of clinical use, predictable mechanical behavior. However, stainless steel also has certain limitations, including greater stiffness compared to bone, which may contribute to stress shielding. Titanium alloys, on the other hand, offer lower elastic modulus compared to stainless steel, improved biocompatibility, reduced imaging artifact, potentially improved load sharing with bone. Because titanium is less stiff than stainless steel, it has been suggested that titanium implants may promote more favorable bone healing conditions. However, reduced stiffness may also affect construct strength, depending on design. The biological advantages of titanium extend beyond simple biocompatibility. Research has demonstrated that titanium alloys exhibit a lower infection rate when compared with stainless steel in experimental models. One possible explanation for this difference relates to tissue interaction with the implant surface. Studies have shown that soft tissue adheres firmly to titanium implant surfaces, whereas a known reaction to steel implants is the formation of a fibrous capsule that encloses a liquid-filled void. This distinction is clinically relevant because bacteria can spread and multiply freely in this non-vascularized space around steel implants, which is also less accessible to host defense mechanisms. In contrast, the firm tissue adherence to titanium creates a barrier that is less conducive to bacterial colonization and proliferation. The study references experimental work performed in rabbit models. In one such study, rabbit tibiae were inoculated with Staphylococcus aureus and fixated with either a point contact fixator plate or a dynamic compression plate. That study demonstrated a lower infection rate of 26% with the point contact fixator when compared with a 63% infection rate with the dynamic compression plate. Another rabbit study specifically comparing titanium to stainless steel found that titanium was associated with reduced infection rates. This finding has been replicated in multiple experimental models. The novel bone plate evaluated in the present study is manufactured from a titanium aluminum vanadium alloy, abbreviated as TAV. The screws used with this plate are manufactured from a titanium aluminum niobium alloy, abbreviated as TAN. Both of these alloys have higher static and fatigue strengths than commercially pure titanium or stainless steel. Titanium alloys also have a lower modulus of elasticity compared with stainless steel, and thus possess much higher strain tolerance, both under static and cyclic loading. This combination of high strength with lower stiffness represents a potentially advantageous mechanical profile for orthopedic applications. The higher strain tolerance may allow the implant to deform elastically under physiologic loads without permanent deformation or failure, while the lower stiffness may promote more favorable load sharing with bone during the healing period. We will now move on to plate design considerations. In addition to material selection, plate geometry and screw configuration play an important role in construct performance. Variables include plate thickness, plate width, hole spacing, screw diameter, screw trajectory, monocortical versus bicortical fixation. TPLO plates are typically contoured to fit the proximal tibia and may include features designed to optimize fixation in the metaphyseal bone of the tibial plateau segment. The study upon which this lecture is based compares two plate constructs that differ not only in material, but also in design philosophy. The novel TPLO fixation device that serves as one of the test groups in this study was developed specifically with design features targeted to reduce surgical site infection rates by ensuring tissue perfusion under the plate. Key design features of this novel plate include titanium alloy material, distal monocortical screw fixation, a point contact undersurface. The point contact undersurface is a specific design element intended to minimize the area of direct contact between the plate and the bone. This design philosophy has its origins in human orthopedic implant development. In 1993, the AO Institute developed a novel bone plate called the point contact fixator, abbreviated as PC-Fix. The PC-Fix was the first true internal fixator and employed point contact only on the bone surface, as well as angle stability of screws achieved by a conical connection between screw heads and screw holes. The goal of this design was to reduce the impact of implant placement on periosteal blood supply. Why? The reasoning was straightforward. If less of the plate surface is in direct contact with the bone, there will be less disruption of the blood vessels that supply the outer surface of the bone from the periosteo. In addition, the locking design permitted stability with monocortical screw placement, which theoretically reduces disruption to endosteal blood supply. The endosteum is the membrane lining the inner surface of the bone, and it also contributes to the bone's blood supply. Why? The result of these design modifications was faster healing and reduced infection rates when compared with the dynamic compression plate, which was a standard plate design at that time. A prospective multicenter study of 1,229 PC fixators placed in human patients reported an infection rate of 1.1%, which was lower than that reported with the dynamic compression plate in comparable clinical scenarios. One of the notable design differences between the novel titanium alloy plate and the comparator stainless steel plate used in this study relates to screw fixation strategy in the distal tibial segment. The novel titanium alloy plate utilizes monocortical screws in the distal segment, meaning that the screws engage only the near cortex of the bone and do not penetrate through to the far cortex. The comparator stainless steel plate utilizes bicortical screws in the distal segment, meaning that the screws penetrate both cortices of the bone. The rationale for monocortical fixation in the context of locking plate technology is based on the previously described mechanism of stability. Because locking screws create a fixed angle construct where the screws lock into the plate itself, they do not rely solely on the friction between screw threads and bone for stability. Instead, stability is achieved through the unified construct of plate and screws acting together. The study notes that previous research has demonstrated that locking monocortical plate constructs can confer biomechanical performance equivalent to locking bicortical constructs in certain applications. Specifically, the study cites work on greyhound femurs demonstrating that axially loaded locking monocortical plate rod constructs showed no biomechanical difference compared to those employing locking bicortical screws. It is important to note, however, that in the present study, monocortical screws were placed only in the diaphyseal bone of the tibia distal to the osteotomy, where the bone is denser and more cortical in nature. Bicortical screws were still used in the softer metaphyseal bone proximal to the osteotomy in both groups, although the study acknowledges that evidence to definitively support this practice is currently lacking. We will now move on to the rationale for biomechanical testing. Before new implant designs are widely adopted in clinical practice, they are often subjected to biomechanical testing. Such testing aims to evaluate the mechanical performance of implants under controlled laboratory conditions. Biomechanical studies can assess parameters such as construct stiffness, load to failure, mode of failure, fatigue resistance. While biomechanical testing cannot replicate all aspects of in vivo conditions, it provides valuable information regarding the relative performance of different implants. The study in question seeks to determine whether a novel titanium alloy locking plate construct provides biomechanical performance comparable to that of an established stainless steel locking plate construct when used for TPLO fixation. The study explicitly references a regulatory framework used in human orthopedic medicine. In the human orthopedic industry, it is commonplace for novel devices to be evaluated by the Federal Drug Administration, abbreviated as FDA, for substantial equivalence to a previously cleared device, known as a predicate device, in lieu of testing in independent clinical trials. This FDA clearance mechanism is referred to as the 510(k) pre-market notification process. The logic of this regulatory pathway is that if a novel device can be shown to be substantially equivalent to a device that has already been cleared for clinical use and has an established safety and efficacy profile, then the novel device can be approved without the time and expense of full clinical trials. With this established regulatory framework in mind, the investigators of the present study sought to evaluate the novel titanium alloy distal monocortical locking screw plate device for substantial mechanical equivalence to a predicate stainless steel bicortical locking conventional screw plate device before pursuing clinical studies to investigate its potential to affect surgical site infection rates. The choice of the term substantial equivalence is deliberate and significant. The study is not claiming that the two devices are identical in performance. Rather, it is evaluating whether they are sufficiently similar in mechanical behavior that the novel device could reasonably be expected to perform adequately in clinical use. The study objective. The primary objective of the study is not to evaluate clinical outcomes, complication rates, or long-term healing, but rather to compare the biomechanical properties of two TPLO plate constructs under standardized testing conditions. Specifically, the study aims to determine whether differences in material composition and plate design result in meaningful differences in mechanical performance. This distinction is important, and it bears repeating. The study does not claim to demonstrate superiority in a clinical sense. Instead, it focuses on controlled mechanical outcomes. The specific hypothesis tested in this study was stated explicitly by the investigators. The hypothesis was that there would be no difference in load to failure between the two fixation devices when evaluated as load-sharing TPLO implant bone constructs applied to paired canine cadaveric hind limbs. This null hypothesis represents a conservative starting assumption. The investigators are not assuming that one device is better than the other. Rather, they are testing whether any difference exists at all. Having now spent a considerable amount of time establishing the clinical context, surgical background, implant considerations, and theoretical motivations for the study, we are prepared to proceed, slowly and deliberately, toward a detailed discussion of the experimental design and methodology. In the next section, we will examine the cadaveric model used, the preparation of specimens, the surgical technique as applied in the laboratory setting, the biomechanical testing protocol. This will be done carefully, step by step, with attention to detail and terminology. We will now proceed to a detailed discussion of the materials and methods employed in the biomechanical study. This portion of the lecture will focus on specimen selection, preparation, surgical technique, and implant application. As is appropriate for a method section, the presentation will emphasize accuracy, completeness, and procedural detail, with minimal interpretation or commentary. The purpose of this section is not to persuade or entertain, but to describe, in a reproducible manner, how the experiment was conducted. The study was designed as a controlled, cadaveric biomechanical comparison between two tibial plateau leveling osteotomy fixation constructs. Each construct utilized a locking plate system, differing primarily in material composition and design characteristics. One construct employed a novel titanium alloy locking plate, while the comparator construct employed an established stainless steel locking plate that has been widely used in clinical practice. The experimental model involved the use of paired canine tibiae harvested from cadaver specimens. By using paired limbs, the investigators sought to reduce inter-individual variability related to size, bone quality, and anatomy. The use of paired limbs from the same animal is a well-established experimental design strategy in biomechanical research. The fundamental advantage of this approach is that each animal effectively serves as its own control. Because the two tibiae from a single dog are presumably very similar in size, shape, bone density, and mechanical properties, any differences observed between constructs can more confidently be attributed to the implant itself rather than to inherent differences in the bow. This paired design increases statistical power and reduces the number of animals required to detect meaningful differences between groups. Cadaveric specimens were obtained from skeletally mature dogs that had been euthanized for reasons unrelated to the study. The study specifies that 8 dogs were used, with breeds described as mixed breed dogs weighing approximately 20 to 30 kilograms. Criteria for inclusion of specimens included skeletal maturity, absence of gross orthopedic pathology, no prior surgical intervention involving the tibia, acceptable bone quality upon visual inspection, absence of radiographically detectable dis-ease, specimens exhibiting evidence of previous fracture, deformity, or advanced degenerative joint disease were excluded. The use of cadaveric specimens allows for standardized preparation and testing conditions, while eliminating variables associated with pain, healing response, and biological adaptation. The study specifies that the dogs weighed approximately 20 to 30 kilograms. This size range represents medium-sized dogs and is clinically relevant because dogs in this weight range are commonly affected by cranial cruciate ligament disease and are frequently candidates for TPLO surgery. Upon examination of the data table provided in the study, it can be observed that the actual breed composition included pit bulls, Labrador mixes, and a German Shepherd dog. These breeds and breed types are representative of the population of dogs that commonly undergo TPLO in clinical practice. The specific breed composition is documented in the study's results table, which will be discussed in detail later in this lecture. We will now move on to specimen handling. After collection, tibiae were carefully dissected free of surrounding soft tissues, with care taken to preserve the integrity of the bone. Residual soft tissue attachments were removed to allow for precise osteotomy and implant placement. The study provides specific information regarding specimen storage and handling procedures. The dogs had been frozen immediately after euthanasia at -20 degrees Celsius. The specimens were then thawed at room temperature for 48 hours before limb harvest. After harvest, limbs were stored in a refrigerated environment at 2 to 8 degrees Celsius and tested within 48 hours of THA. All limbs were confirmed to be free of radiographically detectable disease before inclusion in the AUDITORY. Throughout preparation and testing, specimens were periodically moistened with saline to prevent desiccation. The use of frozen cadaveric specimens raises the question of whether freezing and thawing affect the mechanical properties of bone in ways that might influence study results. The study addresses this concern by citing previous research on the subject. Specifically, the investigators reference a study that investigated fracture and fatigue in osteocytes after cyclical loading of bovine bone specimens. That study demonstrated that freezing bone samples did not affect the fatigue behavior or incidence and types of cracks in bone. Another study cited by the investigators examined the effects of freezing on porcine trabecular bone. That study demonstrated a loss of compressive strength of trabecular bone from freezing. However, while there was a significant difference in compressive strength after 5 years of freezing, there was no significant difference if the bone was only frozen for 1 year or less. The investigators note that all bones in the present study were frozen for less than 1 year. Furthermore, the paired design of the study means that both limbs from each dog experienced identical storage conditions, so any effects of freezing would affect both groups equally and would therefore not bias the comparison between groups. Paired tibiae from each cadaver were randomly assigned to one of the two fixation groups. Group 1, TPLO fixation using the novel titanium alloy locking plate construct, designated as the TA group. Group 2, TPLO fixation using the established stainless steel locking plate construct, designated as the SS group. By using paired limbs, each dog effectively served as its own control, thereby reducing variability related to size and bone density. The study specifies that randomization was performed via computer randomization. This means that the assignment of which limb received which implant type was determined by a random number generator, rather than by investigator choice. Randomization is an important methodological feature because it minimizes allocation bias. Without randomization, investigators might consciously or unconsciously assign limbs to groups in ways that could favor one treatment over another. The study explicitly states that limbs were randomly assigned and that the contralateral limb of each cadaver was assigned to the opposite treatment group to minimize variability. Prior to performing the osteotomy, several measurements were obtained for each tibia. These measurements are relevant both for surgical planning and for subsequent normalization of biomechanical data. Measurements included tibial length, proximal tibial width, tibial plateau angle, E. The tibial plateau angle was measured using standard radiographic techniques. This measurement is of particular importance in TPLO surgery, as it determines the degree of rotation required to achieve the target postoperative angle. The study notes that preoperative radiographic planning was performed to determine the desired rotation and saw blade positioning, just as would be done for clinical case. This attention to surgical planning is important because it ensures that the experimental procedure closely mimics clinical practice. By following the same preoperative planning process that would be used in actual patients, the investigators increase the clinical relevance of their findings. The study also notes that care was taken to ensure adequate tibial tuberosity size cranial to the osteotomy. A minimum of 10 mm was specified, or as judged by the surgeon based on patient size. This consideration is important because insufficient tibial tuberosity size can lead to fracture, which is a recognized complication of TPLO surgery. Why? We will now move on to the TPLO osteotomy technique. The tibial plateau leveling osteotomy was performed using a standardized technique consistent with commonly accepted clinical practice. The osteotomy consisted of a curved cut through the proximal tibia, centered on the intercondylar eminence. A commercially available TPLO saw blade and jig system from Slocum Enterprises were used to ensure consistency across specimens. Steps of the osteotomy included positioning the tibia in a stable orientation, placement of the TPLO jig, execution of the curved osteotomy, rotation of the proximal segment to the predetermined angle. The study notes that a jig was used during the procedure, and that the distal jig hole was placed in the center of the tibial diaphysis to avoid creating a stress riser during testing. This is an important detail because a stress riser, an area where stress concentrates in a structure, could lead to premature failure during mechanical testing that would not reflect the actual strength of the implant construct. The degree of rotation was calculated to achieve a postoperative tibial plateau angle consistent with TPLO principles. While the study does not specify the exact target angle, standard TPLO technique typically aims for a postoperative tibial plateau angle in the range of approximately 5 degrees. The study also specifies that in the stainless steel group, the osteotomy and rotation were performed to match the contralateral limb. This ensures that both limbs from each pair received identical rotational corrections, eliminating any potential bias that might result from differences in surgical planning between groups. After rotation of the tibial plateau segment, fixation was achieved using one of the two locking plate constructs under investigation. In both groups, plates were applied according to manufacturer guidelines and standard surgical technique. Key principles of plate application included accurate plate positioning, proper screw insertion torque, avoidance of intra-articular screw placement, maintenance of rotational alignment. Care was taken to ensure that plate placement was consistent between groups to the extent possible. An important methodological detail is that different surgeons performed the procedures for each group. The study specifies that in the titanium alloy group, TPLO was performed by a board-certified surgeon who was experienced with the technique and who is identified in the authorship list. In the stainless steel group, routine TPLO was performed with an established stainless steel locking TPLO plate by a different board-certified surgeon, also experienced with the technique. Both surgeons were board-certified, meaning they had completed additional specialized training and examination in veterinary surgery beyond their basic veterinary degree. The study acknowledges in its discussion that the use of different surgeons for each group represents a limitation, inasmuch as surgeon influence on results cannot be excluded. However, both surgeons were experienced with TPLO technique, which should minimize technique-related variability. The novel titanium alloy locking plate used in the study was designed specifically for TPLO applications. The plate is manufactured by Kion Veterinary Surgical Products, located in Zurich, Switzerland. The plate geometry was contoured to match the proximal tibial anatomy and included locking screw holes arranged to optimize fixation in the metaphyseal region. All screws used in the titanium alloy group were 4.0 mm diameter titanium alloy locking screws. The study specifies the exact screw configuration. 3 screws in the distal segment were monocortical per manufacturer recommendations, and 3 screws in the proximal segment were bicortical. The study provides a detailed description of the screw placement sequence. The osteotomy was compressed with a conventional 3.0 mm diameter bicortical screw in the proximal hole after placement of the distal screws. This initial compression screw helps to close the osteotomy gap and ensure good bone-to-bone contact at the osteotomy site. After filling all remaining screws, the 3.0 mm proximal conventional compression screw was then replaced with a 4.0 mm bicortical locking screw per manufacturer guidelines. This sequential approach is part of the manufacturer's recommended technique and is designed to achieve both compression at the osteotomy site and stable locking fixation. Titanium alloy plates are characterized by lower elastic modulus compared to stainless steel, reduced stiffness, potential for improved load sharing, higher static and fatigue strength than commercially pure titani. The plate thickness and hole configuration were designed to balance strength with flexibility. Locking screws were inserted into the plate at predetermined angles, engaging the threaded plate holes to create a fixed angle construct. The point contact undersurface design means that the plate does not rest flat against the bone surface along its entire length. Instead, it makes contact with the bone only at specific points, leaving gaps between the plate and bone in other areas. This design is intended to preserve periosteal blood supply. The comparator plate was an established stainless steel locking plate with a history of clinical use in TPLO procedures. The specific plate used was manufactured by DePuy Synths, located in New Brunswick, New Jersey, USA. Stainless steel plates are generally stiffer than titanium plates, which may influence construct behavior under load. The stainless steel plate used in this study featured a similar overall plate length to the titanium plate. Locking screw technology. A design optimized for proximal tibial fixation. As with the titanium plate, screws were inserted according to manufacturer specifications. In the stainless steel group, 3.5 mm diameter bicortical conventional screws were placed in the distal fragment and 3.5 mm diameter bicortical locking screws were placed in the proximal segment using a manufacturer-recommended compression technique. It is important to note the differences in screw diameter and type between the two groups. The titanium alloy group used 4.0 mm screws throughout, while the stainless steel group used 3.5 mm screws. The titanium alloy group used locking screws throughout after the initial compression step, while the stainless steel group used conventional screws in the distal segment and locking screws in the proximal segment. The stainless steel group used bicortical screws in both the distal and proximal segments, while the titanium alloy group used monocortical screws in the distal segment. These differences reflect the different manufacturer recommendations and design philosophies for the two plate systems. The study notes that bicortical screw fixation was assured in the stainless steel group, but screw length was not optimized, meaning that excessive screw length was accepted. This decision was made to minimize screw inventory required for the study. In clinical practice, surgeons typically select screws of appropriate length to just barely penetrate the far cortex, but for this experimental study, longer screws were used to ensure bicortical purchase without requiring a large inventory of screws of different lengths. Both constructs utilized a combination of screws placed in the proximal and distal segments of the tibia. Screw characteristics included locking screw heads, in all titanium alloy screws and proximal stainless steel screws. Threaded engagement with the plate. Monocortical or bicortical fixation, depending on location. In general, proximal screws were placed in the softer metaphyseal bone, while distal screws were placed in the denser diaphyseal bone. This anatomical difference influenced screw configuration recommendations. Screw placement was carefully documented, and efforts were made to ensure comparable screw number and distribution between constructs to the extent possible given the different manufacturer recommendations. After plate application, each specimen was visually inspected to confirm proper plate seating, secure screw fixation, maintenance of the desired tibial plateau angle. Radiographs were obtained to verify implant positioning and alignment. The study provides example radiographs showing orthogonal views of stifles in both the titanium alloy group and the stainless steel group. Any specimens exhibiting gross malalignment or technical error would have been excluded from further testing, although the study does not report any such exclusions, suggesting that all prepared specimens met quality standards. Following fixation, specimens were prepared for biomechanical testing. The study describes a specific mounting strategy designed to simulate physiologic loading conditions. The distal end of each tibia was not embedded in potting material, as is sometimes done in simpler biomechanical tests. Instead, a more complex mounting strategy was employed that preserved the entire stifle joint. The study notes that after removal of musculature, all limbs were tested in a servo-hydraulic testing machine. The mounting strategy deserves careful description because it differs from simpler compression tests and was designed to more closely approximate in vivo loading conditions. The limbs were positioned with the stifles at 135 degrees to correspond with standing angle during mid-stance phase. This joint angle was specifically chosen because it represents the configuration of the limb during weight bearing. The metatarsals, the bones in the foot, were fixed with screws to a wooden base. This provided a stable platform from which to apply load. The load was applied to the femoral head along a line connecting the femoral head to the tarsus. This loading vector was chosen to approximate the line of action of body weight during standing. An important feature of the testing setup involved the patella. The patella was fixed to the distal femur with multiple Kirschner wires drilled at an oblique angle and tied to a pair of K-wires inserted through the midshaft of the femur in the frontal plane by a high-strength braided ultra-high molecular weight polyethylene suture. The specific suture used was power fiber, manufactured by CP Medical I, NC. This fixation of the patella was done to simulate worst-case scenario maximal quadriceps muscle group stiffness. In the living animal, the quadriceps muscles would normally provide some compliance and shock absorption. By rigidly fixing the patella, the investigators created a more severe testing condition that eliminates this natural shock absorption. The study notes that this methodology also minimized interconstruct variability. Because the quadriceps mechanism was rigidly fixed in the same manner for all specimens, any variation in how this soft tissue system might respond to load was eliminated. The biomechanical testing setup was designed to simulate axial loading conditions representative of weight bearing in the canine hind limb. While it is acknowledged that in vivo loading involves complex, multidirectional forces, axial compression testing provides a controlled and reproducible method for comparing construct performance. The investigators selected this approach to focus on differences attributable to implant design rather than variability in loading conditions. The study acknowledges in its discussion that there are limitations inherent in this approach. There were no muscles on the tested constructs, and the complex forces associated with walking were not perfectly replicated. However, the testing method did permit comparison of constructs using paired limbs, which reduced variables in bone strength. The goal was to strike a balance between clinical relevance and experimental control. The mounting strategy preserved the intact stifle and applied loads along a physiologically relevant vector, while the rigid fixation of the patella and standardized loading protocol ensured reproducibility. At this point in the study, the specimens had been selected, prepared, osteotomized, fixed with one of two plate constructs, mounted for testing. We are now prepared to proceed to a detailed discussion of the biomechanical testing protocol itself, including loading parameters, data acquisition, and definitions of failure. This will be addressed in the next section. In this portion of the lecture, we will examine the biomechanical testing protocol employed in the study. This section will describe, in careful and extended detail, the manner in which loads were applied to the specimens, how mechanical data were collected, and how key variables such as stiffness and failure were defined. D. As is appropriate for a biomechanical method section, the discussion will focus on procedural clarity rather than interpretation. Interpretation will be deferred until later sections of the lecture. The primary purpose of biomechanical testing in this study was to compare the mechanical performance of two TPLO fixation constructs under controlled laboratory conditions. NS. Specifically, the investigators sought to evaluate construct stiffness, load at failure, mode of fail, U. These parameters were selected because they provide insight into how a fixation construct may behave under physiologic loading conditions during the postoperative period. OD. It is important to reiterate that biomechanical testing does not replicate the biological environment of a living animal. Instead, it isolates mechanical behavior in order to facilitate direct comparison between constructs. Biomechanical testing was performed using a materials testing system capable of applying controlled axial loads to the specimens. The specific machine used was a mini Bionix 858, manufactured by MTS Systems Corporation, located in Eden Prairie, Minnesota, USA. The testing system included a 5,000 Newton force transducer to measure applied fear. RC. Such systems typically consist of a load frame, an actuator capable of applying compressive force, a load cell to measure applied force, a displacement transducer to measure deformer. Tie-on. The testing system would have been calibrated prior to testing to ensure accuracy of force and displacement measuring. NTS. Calibration is a critical step in biomechanical testing, as even small inaccuracies in measurement can influence calculated stiffness value. Each prepared tibial specimen was mounted in the testing apparatus in the standardized orientation previously described, with stifles at 135 degrees, metatarsals fixed to a wooden base, patella rigidly fixed, and load applied to the femoral head. Careful alignment was essential to minimize off-axis loading, which could introduce bending moments or shear forces that were not intended as part of the testing PROT. OCOL. The study provides a photograph showing TPLO constructs positioned in the servo-hydraulic testing machine before testing. The photograph shows examples of constructs from both the titanium alloy group and the stainless steel group, illustrating the mounting configurat. ION. The investigators selected axial compression as the primary mode of loading for several reasons. First, axial compression represents a major component of the forces experienced by the tibia during weight bearing. Second, axial compression testing is relatively straightforward to standardize and reproduce across specimens. Third, axial loading allows for direct comparison of construct stiffness and failure characteristics without introducing excessive variability. It is acknowledged that the canine tibia experiences complex loading patterns in vivo, including torsion and bending. However, axial compression testing provides a useful approximation for comparative purposes. Before the primary loading protocol was initiated, specimens were subjected to a preconditioning phase. The study specifies that all limbs were preconditioned for 10 cycles at 0.25 Hz with 5 mm of displacement before being ramped to failure. Preconditioning involves the application of low-magnitude cyclic loading to settle the construct and eliminate slack within the testing system. This process helps to ensure that subsequent measurements reflect true construct behavior rather than artifacts related to initial seating of the specimen. The frequency of 0.25 Hz means that each cycle took 4 seconds to complete. A displacement of 5 mm means that the actuator moved 5 mm downward, then returned to its starting position for each cycle. The specifics of preconditioning, including load magnitude and number of cycles, were standardized across specimens. After preconditioning, axial load was applied to the specimen in a controlled manner. The study specifies that specimens were ramped to failure at a rate of 1 mm per second until either implant failure or stifle collapse occurred. This means that load application was performed at a constant displacement rate. The actuator moved downward at a fixed speed of 1 mm per second, and the resulting force was measured by the load cell. A constant displacement rate allows for consistent comparison between specimens and avoids sudden application of force that could artificially induce failure. The load was increased continuously until construct failure occurred. Construct stiffness is a measure of resistance to deformation under applied load. In this study, stiffness was calculated from the linear portion of the load displacement curve generated during testing. The load displacement curve plots applied force on the vertical axis and corresponding displacement on the horizontal axis. The slope of the linear region of this curve represents stiffness, typically expressed in units of force per unit displacement, such as newtons per millimeter. Only the linear elastic region of the curve was used for stiffness calculation, as this region reflects reversible deformation. Although the study reports load to failure values and modes of failure, it does not explicitly report stiffness values in the results section. This may be because stiffness was not a primary outcome measure, or because the more complex loading arrangement with the intact stifle made stiffness calculations less straightforward than they would be in a simple compression test. The study focuses primarily on load to failure as the key outcome measure. The load displacement curve provides a visual representation of construct behavior under low A.D. At low loads, the curve typically exhibits a linear relationship between force and displacement. As load increases, the curve may deviate from linearity, indicating the onset of plastic deformation or microfailure. Eventually, a peak load is reached, beyond which the construct can no longer sustain increasing fork. This peak load is often referred to as the load at failure, and it is the primary outcome measure reported in this study. Failure was defined according to specific criteria established prior to testing. The study describes failure as occurring when the load was increased continuously until either implant failure or stifle collapse occur. Failure may be characterized by sudden loss of load-bearing capacity, gross deformation of the construct, fracture of the bone, breakage or bending of the plate, screw pull-out or breakage, soft tissue failure within the stifle jaw. In biomechanical studies, it is important to clearly define what constitutes failure in order to ensure consistency across specimens. The first occurrence of a predefined failure criterion was recorded as the point of failure, and the load at that moment was recorded as the load to failure. In addition to recording the load at failure, the investigators documented the mode of failure for each specimen. Failure modes provide insight into how and where the construct fails under load. The mode of failure can influence interpretation of mechanical performance and may have implications for clinical application. Specifically, if failures consistently occur in the bone rather than in the implant, this suggests that the implant is stronger than the bone it is fixing. Conversely, if failures occur through implant breakage or screw pullout, this might indicate that the implant itself is the weak link in the construct. The study recorded detailed information about failure modes for each specimen, which will be presented in the results section. Force and displacement data were recorded continuously throughout testing using the data acquisition system associated with the testing machine. Data would have been sampled at a sufficiently high frequency to capture detailed information about construct behavior. All data were stored digitally for subsequent analysis. Care would have been taken to label and organize data files to ensure traceability of each specimen. The study employed specialized statistical methods appropriate for the paired design and small sample size. Statistical analyses were performed at the Clinical Trial Unit of the University Hospital, Basel, Switzerland. The software used included our version 3.6.3, along with several specific packages for data handling and analysis. Because the small sample size, 8 limb pairs, did not permit assessment of distribution normality that would be required for a standard parametric test, and because the data did not permit assessment of symmetry around one, a randomization test was performed. This statistical approach is appropriate for small sample sizes and makes fewer assumptions about the underlying distribution of the data than traditional parametric tests such as t-tests. The geometric mean and a 95% bootstrap normal confidence interval were calculated for the ratios in the observed data. The confidence interval was estimated using 999 bootstrap repetitions. Bootstrap methods are resampling techniques that can provide robust estimates of confidence intervals even when sample sizes are small or distributional assumptions are uncertain. Normality of the bootstrap repetitions was assessed visually using a normal QQ plot. The level of statistical significance was predefined, and results would be considered statistically significant if the p-value was less than 0.05. To summarize, the biomechanical testing protocol involved standardized specimen mounting with intact stifle at 135 degrees. Rigid fixation of the patella to simulate worst-case quadriceps stiffness. Axial compression loading applied to the femoral head. Preconditioning for 10 cycles. Ramping to failure at 1 mm per second. Continuous data acquisition. Determination of load at failure. Documentation of failure mode. This protocol was applied consistently across all specimens in both groups. Having now described, in detail, the procedures used to generate mechanical data, we are prepared to examine the results of the study. In the next section of the lecture, we will review load at failure comparisons, observed modes of failure, statistical analysis of differences between groups. This review will be conducted carefully and systematically, with minimal interpretation at first. This section of the lecture will present the results of the biomechanical testing. The emphasis here will be on reporting observed findings in a structured and orderly manner. Interpretation and broader discussion will be deferred until later sectio. NS. The results will be presented under 3 primary headings: load to failure, mode of failure, statistical analysis. Each of these parameters will be addressed individually. Why? The final dataset consisted of 16 paired tibial specimens that successfully underwent preparation, fixation, and biomechanical testing without technical complicati. ONS. This represents 8 pairs of limbs from 8 dogs. All specimens included in the final analysis met the predefined inclusion criteria and completed the full testing protocol. Paired analysis was used, meaning that each tibial specimen fixed with a titanium alloy plate was directly compared to its contralateral counterpart fixed with the stainless steel PL8. This pairing is important to remember, as it reduces variability related to specimen size and bone quality. The study provides a detailed table documenting specific information for each specimen, including the breed of the dog, which leg, right or left, was tested, which group it was assigned to, the load of failure measured in newtons, and the mode of failure observed. Examination of the detailed results table reveals the specific breed composition of the study population. The 8 dogs consisted of 6 pit bulls, representing 12 limbs, 1 Labrador mix, representing 2 limbs, 1 German Shepherd dog, representing 2 limbs. This breed composition is clinically relevant because these are breeds that commonly present with cranial cruciate ligament disease and undergo TPLO surgery in clinical practice. The predominance of pit bull type dogs in the sample reflects the population of dogs available at the time of specimen collection and is not necessarily representative of all dogs undergoing TPLO. The load to failure values for individual specimens in the titanium alloy group, as reported in the study's data table, were 756 N, 674 N, 840 N, 698 N, 779 N, 776 N, 456 N, 756 N. The study reports that the mean load to failure in the titanium alloy group was 716.71 plus or minus 109.50 newtons. The range of values extended from a minimum of 455.69 newtons to a maximum of 839.69 newtons. It should be noted that the minimum and maximum values reported in the text, 455.69 N and 839.69 N, are slightly different from the values shown in the data table, 456 N and 840 N, likely representing rounding in the table versus more precise values in the statistical analysis. The load to failure values for individual specimens in the stainless steel group, as reported in the study's data table, were 543 N, 649 N, 817 N, 497 N, 718 N, 684 N, 273 N, 856 N. The study reports that the mean load to failure in the stainless steel group was 629.50 plus or minus 176.83 newtons. The range of values extended from a minimum of 272.58 newtons to a maximum of 856.18 newtons. Again, slight differences between table values and reported values reflect rounding. Comparing the mean values between groups. Titanium alloy group mean 716.71 N. Stainless steel group mean 629.50 N. Difference in means 87.21 N. The titanium alloy group demonstrated a higher mean load to failure than the stainless steel group by approximately 87 newtons. This represents an increase of approximately 14%. However, examination of the standard deviations reveals substantial variability within each group. The stainless steel group had a particularly large standard deviation of 176.83 N, indicating considerable spread in the data. The range of values within each group deserves attention. Titanium alloy group range 455.69 to 839.69 N, span of 384 N, stainless steel group range, 272.58 to 856.18 N, span of 583.6 N. The stainless steel group exhibited greater variability, with one specimen, the one that failed at 273 N, performing substantially worse than others in its group. This variability reflects natural differences in bone strength and construct behavior among specimens, despite efforts to standardize preparation and testing conditions. The study employed a randomization test to compare the two groups, as previously described in the methods section. The results of this statistical analysis are presented in a dedicated table. The randomization test identified 8 extreme observations and evaluated all 256 possible combinations of group assignments. The p-value from the randomization test was 0.031. Because this p-value is less than 0.05, the difference is considered statistically significant. The study reports that the average ratio of the loads to failure of the paired specimens was 1.18, with a p-value of 0.031. This ratio indicates that, on average, the titanium alloy constructs failed at loads approximately 1.18 times higher than their paired stainless steel counterparts. The 95% confidence interval for the ratio between the strength of limbs operated with the two plates was 0.99, 1.27. This confidence interval is important because it includes values very close to 1.0, specifically the lower bound of 0.99, suggesting that while the observed difference was statistically significant, the magnitude of the difference is modest. The hypothesis stated at the beginning of the study was that there would be no difference in load to failure between the two fixation devices. This null hypothesis was rejected based on the statistical analysis. The ratio of load to failure was significantly greater in the titanium alloy group compared with the stainless steel group, with p equals 0.031. However, it is important to note that statistical significance does not necessarily equate to clinical significance. While a statistically significant difference was detected, the confidence interval ranging from 0.99 to 1.27 suggests that the true difference between groups might be quite modes. The study concludes that substantial mechanical equivalence of the novel titanium alloy construct with the predicate stainless steel construct was demonstrated in this single load to failure testing model, despite the statistical difference. This conclusion reflects the fact that both constructs withstood loads well in excess of physiologic demands, and the observed difference, while statistically significant, was relatively modest in magnitude. The study documented the specific mode of failure for each specimen. These failure modes provide important information about where and how the constructs failed under load. Observed failure modes across both groups included tibial tuberosity fracture, 3 specimens, patellar tendon avulsion, 4 specimens, lateral construct collapse, 3 specimens, medial collateral ligament rupture, 2 specimens, fibular fracture, 1 specimen, tibial fracture, 1 specimen, screw pullout, 1 specimen, various combinations of the above, 1 specimen. The study notes that only one observed failure could be attributed to the implant construct itself. This case involved screw pullout and fracture associated with the proximal tibia in a dog in the stainless steel group with bicortical locking screws in the proximal segment. Examining the specific failure modes in the titanium alloy group. Dog 1, right leg, patellar tendon avulsion at the patella, 756 N. Dog 2, right leg, lateral construct collapse, 674 N. Dog 3, right leg, patellar tendon rupture, 840 N. Dog 4, left leg, lateral collateral ligament rupture and tibial tuberosity avulsion, 698N. Dog 5, left leg, patellar tendon avulsion at patella, 779N. Dog 6, left leg, tibial tuberosity avulsion, 776N. Dog 7, left leg, lateral collapse, 456N. Dog 8, right leg, fibular fracture and lateral collapse, 6N. Notably, none of the titanium alloy constructs failed through the implant itself. All failures involved either bone fracture or soft tissue disruption within the stifled jaw. Int. Specifically, no failure of the titanium alloy constructs involved the distal fixation with monocortical screws. This finding is particularly important because it demonstrates that the monocortical screw strategy employed in the distal segment provided adequate fixation strain. Examining the specific failure modes in the stainless steel group. Dog 1, left leg, medial collateral ligament rupture, 543N. Dog 2, left leg, lateral construct collapse, 649N. Dog 3, left leg, patellar tendon avulsion at patella, 817N. Dog 4, right leg, tibial tuberosity fracture, 497N. Dog 5, right leg, patellar tendon avulsion at patella, 718N. Dog 6, right leg, tibial tuberosity avulsion, 684N. Dog 7, right leg, medial collateral ligament rupture, 273N. Dog 8, left leg, tibial tuberosity fracture and 3 proximal screws pulled out with cranial fracture, 856N. In the stainless steel group, only one specimen, Dog 8, left leg, demonstrated failure that could be attributed to the implant construct. This specimen exhibited screw pull-out from the proximal segment in addition to fracture at the tibial tuberosity. The study notes that this case had bicortical screws which pulled out of the proximal segment. This suggests that even with bicortical fixation in the proximal segment, screw pull-out can occur if loads are sufficiently high or if bone quality is compromised. When failure modes were compared between the two groups, no major qualitative differences were observed. Both constructs demonstrated failure patterns consistent with load transfer through the bone and soft tissues rather than catastrophic implant failure. The predominance of failures involving structures other than the implant itself, such as patellar tendon avulsion, tibial tuberosity fracture, collateral ligament rupture, and lateral collapse, suggests that the implants in both groups were sufficiently robust that the bone and soft tissues became the limiting factors under the extreme loading conditions of this test. This finding is generally considered favorable from an implant design perspective, as it indicates that the implants themselves are not the weakest link in the construct. It is important to note that the failure modes observed in this cadaveric study differ from those typically reported in clinical cases following TPLO surgery. The study acknowledges this explicitly in the discussion section, noting that the construct's mode of failure was generally different than what has been reported clinically. In clinical practice, the most common complications following TPLO include surgical site infection, implant loosening, tibial fracture through or near the osteotomy, and patellar tendon disruption. However, the specific failure modes seen in this study, such as patellar tendon avulsion at loads exceeding 700 newtons and medial collateral ligament rupture, are not commonly seen in clinical patients. This discrepancy reflects the limitations of ex vivo biomechanical testing. The extreme loads applied during testing, the rigid fixation of the patella, the absence of muscles, and the progressive loading to failure all create conditions that differ substantially from the physiologic loading experienced by healing TPLO constructs in living patients. Nevertheless, the failure mode analysis provides valuable information about the ultimate strength of different components of the construct and helps identify potential weak points. At the conclusion of biomechanical testing, the following key results were established. The titanium alloy group demonstrated significantly higher load to failure than the stainless steel group, P equals 0.031. The average ratio of loads to failure was 1.18. The 95% confidence interval for this ratio was 0.99, 1.27. Failure occurred primarily in bone and soft tissue structures for both constructs. No failure of the titanium alloy constructs involved the distal monocortical screw fixation. Only one specimen in the stainless steel group demonstrated implant-related failure, screw pullout. These results form the basis for the discussion section that follows. We have now completed the presentation of the mechanical results. In the next section of the lecture, we will begin to interpret these findings and place them within a broader biomechanical and clinical context. This will include discussion of the implications of the statistical findings, the relationship between biomechanical testing and clinical performance, the significance of failure modes, the potential advantages and limitations of the novel titanium alloy construct, limitations of the study methodology, broader implications for implant selection and future research. This section of the lecture marks the transition from the reporting of measured values to the interpretation of those values. As such, it will proceed cautiously, with deliberate pacing and frequent clarification of concepts. The goal is not to arrive quickly at conclusions, but rather to explore the implications of the findings in a systematic and methodical manner. The discussion section serves to contextualize the results of the biomechanical testing within existing knowledge of orthopedic biomechanics, implant design, and TPLO Fixation. In doing so, it seeks to address the following questions. What does the statistical difference in load to failure indicate? How should this difference be interpreted in terms of mechanical equivalence? What do the failure modes reveal about construct behavior? What are the potential implications for clinical use? What are the limitations of the study? What questions remain for future investigation? These questions will be addressed sequentia. LLY. The results rejected the hypothesis that there would be no difference in load to failure between the two fixation devices. The ratio of load to failure was significantly greater in the titanium alloy group compared with the stainless steel group, with P equals 0.031. This finding indicates that, under the unique loading conditions of this experiment, the titanium alloy constructs demonstrated superior mechanical strength compared to the stainless steel constructs. However, the study's interpretation of this finding is carefully nuanced. Despite the statistical significance of the difference, the investigators conclude that substantial mechanical equivalence was demonstrated. The use of monocortical screws has potential biological advantages beyond mechanical considerations. Bicortical screws necessarily penetrate both the near and far cortex of the bone, potentially disrupting both periosteal and endosteal blood supply. Monocortical screws, by definition, only penetrate the near cortex, leaving the far cortex and its associated blood supply intact. While the present study cannot directly assess biological effects such as blood supply preservation, because it used cadaveric specimens without functional blood vessels, the mechanical adequacy of monocortical fixation demonstrated here provides support for its use in clinical practice, where these biological advantages might be realized. The novel titanium alloy plate incorporates a point contact undersurface design, meaning that the plate makes contact with the bone only at specific points rather than resting flat against the bone surface along its entire length. This design feature is intended to preserve periosteal blood supply by minimizing the area of direct contact between the plate and bone. The study references extensive previous work on point contact fixator designs, including both experimental animal studies and clinical human studies. The experimental work demonstrated that point contact designs resulted in lower infection rates compared to conventional plates. For example, in the rabbit study comparing PC fix to dynamic compression plate in the presence of bacterial inoculation, infection rates were 26% versus 63%, respectively. The study notes that as both plates in that experiment were manufactured from commercially pure titanium, the difference in infection rate was attributed to implant design rather than material properties. The present study cannot directly assess infection rates because it is a mechanical study using cadaveric specimens. However, by demonstrating mechanical adequacy of the novel titanium alloy plate with its point contact design, the study provides support for clinical evaluation of whether this design might reduce infection rates in veterinary TPLO patients. The novel titanium alloy used in this study has specific material properties that differ from both stainless steel and commercially pure titanium. The titanium aluminum vanadium alloy used for the plate and the titanium aluminum niobium alloy used for the screws both have higher static and fatigue strengths than commercially pure titanium or stainless steel. At the same time, titanium alloys have a lower modulus of elasticity compared with stainless steel, giving them much higher strain tolerance, both under static and cyclic loading. The combination of high strength with lower stiffness represents a potentially advantageous mechanical profile. Lower stiffness may promote improved load sharing between the implant and bone, potentially reducing stress shielding and promoting more favorable healing conditions. However, the present study did not directly measure construct stiffness, and the mechanical testing was performed to failure rather than involving cyclic fatigue testing. Therefore, the potential advantages of higher strain tolerance and lower stiffness cannot be directly assessed from this study's results. The study acknowledges multiple limitations inherent in its experimental design. These limitations must be carefully considered when interpreting the results and considering their application to clinical practice. The most fundamental limitation is the study's reliance on cadaveric specimens. Cadaveric models, while useful for isolating mechanical variables, lack the biological processes that influence healing in living anima. LS. Specifically absent are inflammatory response, bone remodeling, callus formation, vascular supply, cellular activity at the osteotomy site, tissue healing and adaptat. Ion. As a result, the study cannot address questions related to biological healing, infection resistance, or long-term implant performance in living patients. In a living dog, the tibia is subjected not only to axial compression from body weight, but also to forces generated by muscles, tendons, and ligaments. These forces contribute to bending moments, torsional loading, and shear force. The testing protocol employed in this study applied only axial compression, thereby simplifying the loading environment. While this simplification allows for reproducibility, it does not fully replicate in vivo conditi. ONS. The study acknowledges that there were no muscles on the tested constructs and that the complex forces associated with walking were not perfectly replicated. However, the investigators note that their model permitted comparison of constructs using paired limbs, which reduced variables in bone strength. The method of modeling the quadriceps patella ligament mechanism deserves specific attention as a limitation. The study fixed the patella rigidly to simulate worst-case scenario maximal quadriceps muscle group stiffness. While this approach minimized interconstruct variability, it does not perfectly replicate the dynamic response of the quadriceps mechanism under physiologic condit. Ions. in a living animal, the quadriceps muscles would provide compliance and shock absorption. The rigid fixation used in this study eliminated this natural dampening effect, creating a more severe testing condition. The study notes that evidence for their imperfect modeling is that the construct's mode of failure was generally different than what has been reported clinically. While this validates that the testing conditions were more severe than typical clinical scenarios, it also means that the failure modes observed may not be directly relevant to clinical practice. The study evaluated construct behavior under progressively increasing load until failure. However, in clinical scenarios, implants are exposed to repetitive cyclic loading over an extended period of time. Cyclic loading can lead to fatigue failure, progressive loosening, accumulation of micro-damage. The absence of fatigue testing represents an important limitation. Conclusions regarding long-term durability cannot be drawn from the present data. The study acknowledges this limitation and suggests that future studies could include mechanical testing under cyclic loading conditions to evaluate fatigue behavior. All specimens were tested in a single, standardized orientation with the stifle at 135 degrees. In reality, limb position and joint angle vary during gait. Changes in limb orientation can alter load distribution across the implant and osteotomy site. By restricting testing to a single orientation, the study may not capture worst-case loading scenarios that might occur at different joint angles or limb positions. An important methodological limitation acknowledged by the study is that different board-certified surgeons performed the procedures for each group. This limitation means that surgeon influence on results cannot be excluded. Subtle differences in surgical technique, plate positioning, or screw tightening torque might have contributed to differences in mechanical performance. However, both surgeons were experienced with TPLO technique, which should minimize technique-related variability. Additionally, both surgeons followed manufacturer guidelines and standard surgical principles. The paired design of the study helps to mitigate some effects of surgeon variability, as each surgeon's techniques were applied to half of each paired specimen set. As with many biomechanical studies, the sample size was relatively modest at 8 pairs of limbs. The study acknowledges this limitation explicitly, noting that the small sample size increases the probability of a type 1 error and that results should therefore be interpreted cautiously. Why? While the paired specimen design improves statistical power, a small sample size may limit the detection of subtle differences or may result in observed differences that do not replicate in larger samples. The study notes that a larger sample size might reveal differences not detected here, or might provide more precise estimates of the magnitude of differences. The study compared 2 specific plate constructs. While differences were attributed in part to material composition, it is important to recognize that plate design also varies between manufacturers. The titanium alloy plate tested was manufactured by Kion, while the stainless steel plate was manufactured by DePuy Synthes. These plates differ not only in material but also in specific design features such as plate geometry, hole configuration, and screw specification. Therefore, findings should not be generalized to all titanium or all stainless steel TPLO plates. Rather, the results apply specifically to the constructs tested. This specificity is consistent with the regulatory concept of substantial equivalence, which compares a specific new device to a specific predicate device rather than making broad material-based comparisons. The use of frozen and thawed cadaveric specimens represents another potential limitation. Although the study cites evidence that short-term freezing, less than 1 year, does not significantly affect bone mechanical properties. All bones in the study were frozen for less than 1 year, and the paired design means that both limbs from each dog experienced identical storage conditions. We now move on to the implications of the research. Despite these limitations, the study provides useful information for surgeons considering implant options for TPLO procedures. Specifically, it suggests that titanium alloy locking plates with monocortical distal fixation can provide mechanical performance comparable to, and potentially superior to, that of established stainless steel plates with bicortical fixation in terms of ultimate STRI. This finding may inform decision-making when considering factors such as surgeon preference and experience, implant availability and cost, patient-specific considerations such as bone quality, potential biological advantages of different materials or signs. However, the study emphasizes that implant selection should always be guided by a combination of biomechanical evidence, clinical experience, and patient TORs. The investigators note that while biomechanical equivalence is a necessary prerequisite for clinical adoption, it is not sufficient on its own. Clinical factors such as surgical technique, postoperative management, and patient compliance also influence outcome. The findings of this study suggest several avenues for future investigation. The study notes that future studies could include mechanical testing under cyclic loading conditions. Such testing would provide information about construct behavior under repetitive loading and would allow assessment of fatigue stance. Cyclic testing could involve applying physiologically relevant loads repeatedly over thousands or millions of cycles to determine whether progressive damage accumulation or eventual fatigue failure occurs. The most important direction for future research is clinical evaluation of the novel titanium alloy plate system in actual patients. The study notes that clinical investigation of potential merits of this novel titanium alloy monocortical bicortical locking screw plate system is now warranted. Such clinical studies could assess surgical site infection rates, healing time and quality, complication rates, long-term functional outcomes, cost effectiveness. Clinical outcome studies that combine mechanical testing results with prospective clinical evaluation would be particularly valuable in determining whether the mechanical adequacy demonstrated in this study translates to improved clinical performance. Future research might also investigate the biological effects of different plate designs and materials. Studies could evaluate bone healing quality and speed, blood flow preservation under different plate designs, inflammatory response to different materials, integration of soft tissue with different implant surfaces. Such studies would require in vivo animal models rather than cadaveric specimens. The study's findings have several practical implications for veterinary surgeons performing TPLO procedures. First, the results support the use of monocortical locking screw fixation in the distal tibial segment, which may offer advantages in terms of reduced surgical time, preserved blood supply, and potentially reduced disruption to bone. Second, the demonstration of mechanical adequacy for the novel titanium alloy system provides evidence supporting its consideration for clinical use, particularly in contexts where its potential biological advantages, reduced infection risk, improved biocompatibility, might be particularly valuable. Third, the study reinforces the importance of proper surgical technique in achieving adequate fixation, as demonstrated by the fact that surgical factors likely influence construct performance. More broadly, the study illustrates the role of biomechanics in veterinary orthopedic surgery. By applying engineering principles to biological systems, biomechanical research informs implant design and surgical technique. While not definitive on its own, biomechanical testing provides an essential foundation for evidence-based practice. The study demonstrates how laboratory testing can be used to evaluate new implant designs before widespread clinical adoption, potentially reducing the risk of unexpected complications or failures. The use of the substantial equivalence framework borrowed from human medicine provides a rational pathway for evaluating novel devices without requiring extensive and expensive clinical trials for every minor design modification. The study demonstrates that a novel titanium alloy locking plate construct with monocortical distal fixation exhibits mechanical strength that is statistically superior to an established stainless steel locking plate construct with bicortical fixation under the specific testing conditions employed. More importantly, both constructs demonstrated strength substantially exceeding expected physiologic loads, supporting the conclusion of substantial mechanical equivalent. No failures of the titanium alloy constructs involve the monocortical screw fixation in the distal segment, demonstrating the adequacy of this design feature. These findings provide biomechanical evidence supporting clinical evaluation of the novel titanium alloy plate system, particularly with respect to its potential to reduce surgical site infections through its point contact design and titanium material properties. In conclusion, the study by Bleakley, Palmer, Miller, McGillivray, and Tepic contributes valuable biomechanical data comparing two TPLO fixation approaches. The key findings are: the titanium alloy construct demonstrated significantly higher load to failure, average ratio 1.18, p equals 0.031. Both constructs exceeded physiologic load requirements substantially. No failures involved monocortical screw fixation in the titanium construct. Failures occurred predominantly in bone and soft tissue rather than implants. Substantial mechanical equivalence was demonstrated despite statistical difference. These findings support the continued development and clinical evaluation of the novel titanium alloy TPLO plate system while acknowledging the limitations inherent in cadaveric biomechanical studies. The study provides a foundation for future clinical research to determine whether the mechanical adequacy and theoretical biological advantages of this system translate into improved patient outcomes, particularly with respect to surgical site infection rates. As we conclude the lecture, let's remember the anatomy in question. The cranial cruciate ligament, or CCL, is a primary stabilizing structure within the canine stifle joint. Its function is multifactorial and includes resistance to cranial translation of the tibia relative to the femur, limitation of internal tibial rotation, and contribution to overall joint stability during weight bearing. There is also a meniscus to be considered. It is a cartilage-like structure between the femur and tibia bones. This meniscus serves many important purposes in the joint as well, as its functions include shock absorption, position sensing, and load bearing, among others. The concern is that it can be damaged when the cranial cruciate ligament is ruptured. In dogs, disease of the cranial cruciate ligament is a common orthopedic condition. It is widely recognized as one of the most frequent causes of hind limb lameness in the canine population. Unlike the acute traumatic anterior cruciate ligament rupture often described in human athletes, canine CCL disease is more frequently degenerative in nature, progressing gradually over time before culminating in partial or complete rupture. This degenerative process may be influenced by a number of factors, including but not limited to conformation, body weight, tibial plateau angle, genetic predisposition, chronic inflammation within the joint, age and activity level. The end result of cranial cruciate ligament insufficiency is joint instability. This instability leads to abnormal joint mechanics, pain, progressive osteoarthritis, and functional impairment. The high prevalence of this condition means that any improvement in surgical technique, implant design, or complication reduction has the potential to affect a large number of patients and their owners. Small dog owners have more options, such as conservative or non-surgical management. It is designed to keep up the patient's comfort levels and affected limbs functionality. Conservative management of a torn canine cranial cruciate ligament involves a 6 to 9 month regimen of strict activity restriction. Weight loss, pain management with NSAIDs, and rehabilitation to build muscle are also commonly used. The anti-inflammatory effect is specific for NSAIDs designed for the canine patient. These drugs act by inhibiting the cyclooxygenase (COX) enzyme, specifically COX-2. Glucosamine and chondroitin sulfate are also commonly used to manage the pain from the associated osteoarthritis in the stifle joint. Newer treatments such as autologous conditioned plasma are becoming popular. This is a biological product that consists of an autogenous fluid containing a supraphysiological concentration of platelets. These platelets contain growth factors, and they play an important role in the healing process through the proliferation and differentiation of stem cells. While conservative management may be attempted in some cases, particularly in small dogs or those with limited activity, surgical intervention is commonly recommended for medium to large breed dogs in order to restore function and slow the progression of osteoarthritis. Without surgery, the knee remains unstable, increasing the risk of, or worsening, existing arthritis and potential meniscus damage. As we have discussed, a variety of surgical techniques have been developed over the years to address CCL deficiency. So the next step, and the most important direction for future research, is clinical evaluation of the novel titanium alloy plate system in actual patients. The study notes that clinical investigation of potential merits of this novel titanium alloy monocortical bicortical locking screw plate system is now warranted. To recap, the material presented has covered clinical background of cranial cruciate ligament disease, surgical management with TPLO, implant design considerations including locking plate technology, material science, and design features, detailed experimental methods including specimen selection, preparation, surgical technique, and testing protocols, complete results including load to failure data, failure modes, and statistical analysis. Comprehensive discussion of findings, limitations, implications, and future directions. Thank you for your attention during this session of the Boring Lecture Series. This has been Lecture 4, focused on Canine TPLO Fixation Mechanics. The lecture was based on the paper by Bleakley S., Palmer R., Miller N., McGilvray K., Tepic S., entitled Biomechanical Comparison of Tibial Plateau Leveling Osteotomy Performed with a Novel Titanium Alloy Locking Plate Construct versus an Established Stainless Steel Locking Plate Construct, published in the journal Frontiers in Veterinary Science, 2021, Volume 8, Article 698159, and is available as an open access article. Additional material was sourced from the paper Treatment Tactic of Canine Cranial Cruciate Ligament Rupture Management, a 28-day comparative analysis of ACP and SAID-induced effects on the serum MMP3 levels and clinical outcomes, by Raulinate, Zelvite, Skemiene, and Monkoviscian. This lecture was narrated by Dr. Oanon, an artificial voice for the Boring Lecture Series. Please see the description for further resources and links to the primary literature cited throughout this discussion. If you found this level of detail sufficient, please consider subscribing for our weekly sessions. We will now fade to soothing bioacoustic sounds and drones to allow for a period of quiet reflection or continued rest. Good night.